Good afternoon, everyone, and welcome to this webinar on management and treatment of a breast cancer patient. I'm Andy Thomas, Director at PhysicWhip, and today we're going to be talking about breast cancer. So that's something that affects all of us at some point, either directly or through friends and family. And the focus is often placed on the cancer itself from a life and death perspective. It can sometimes be forgotten how people return to a practical normal life following breast cancer surgery, and this is what today's session will focus on. So once we've had the presentation, we'd love to address any questions that you have, so please put this in the questions tab below and I will answer them. So our presenter today is Rosie Deer. Rosie is a clinical specialist occupational therapist working mainly in the field of upper limb trauma, burns and plastics at University Hospitals Leicester. In addition to managing a complex hand trauma and burns caseload, Rosie has more recently been involved in developing an occupational therapy breast cancer rehabilitation service and future rehabilitation services for individuals who are recovering from COVID-19. From my perspective, it's been great working with Rosie for a long time in regards to the Primus, and she was also one of the first people to trial LymphaTouch from a scarring perspective. She's also one of the most passionate therapists I know, so I'm not setting you up here for to be excitable today, Rosie, but I'm really looking forward to hearing your talk, so I will now pass over to you.
Thanks, Andy. Can you hear me okay, everyone?
Very good.
Okay, perfect. So thanks, Andy. I'm Rosie. I'm an occupational therapist working at Leicester Hospitals. I've watched a few of these webinar series and I've found them really interesting and I've learned a lot. So I love to learn, and I do quite enjoy presenting and teaching. So hopefully I'll learn a lot from your questions, and maybe this will highlight what we're doing at Leicester. So as Andy said, this is a breast cancer case study. I'm going to be focusing it around one of the patients that was first seen in our service, which is quite a new service. We've got established physiotherapy services already, and but for occupational therapy, it's quite a new thing, just started in the last couple of years. So this is what we're going to go through. A bit of a background about the patient, her surgical treatment, the problems she presented with, and how we use the equipment we've got really to treat her, as well as all the other normal interventions we'd do. So yeah, the service was started actually, like Andy said, I'm actually in an upper limb trauma and burns service, and and a hand service with the rest of my colleagues. But this started because I found out that there was an OT over in the States that was doing work with cancer patients very successfully using the Primus, and that's how all this started. I went to see our breast care team to see if they felt there was anything that we could offer, and they were really interested, and so we did a pilot, and this is one of the first people really in the pilot. So I'm going to talk about her and then how the service is developing really since then. So when this lady came to us, as I said, she was one of our first patients. When I kind of started this service in terms of having the ideas, and then I promptly went off to start a family and left my colleagues Sarah and Amy to do all the work. So they saw this patient who was a 41-year-old teacher. Before she got breast cancer, she was fit and well, and no previous trauma and no medical history of note. So we'll go into her problems that she came with a bit more in a minute. So she had a left-sided mastectomy. She had her initial surgery about 5 to 6 months before she was actually referred. But following the surgery, she had some more surgery to remove some lymph nodes a couple of months later. And then she had a course of chemo and then radiotherapy following this. So I think it was after her chemo she developed a bit of cording, and she also developed some mild lymphedema. And so when she presented to us, she was being treated by a specialist local lymphedema team. So when she came to us, her main worry was the pain levels, really, and the discomfort. She had very restrictive, painful, tight scarring across her chest, and especially in the pec area, and especially when she was trying to abduct her shoulder. She had reduced movement, and she was avoiding doing overhead activities with that side, which was quite limiting and also probably not that helpful in terms of the scarring and making it more mobile, and also tight muscles, etc. She had reduced overall function and strength. And like a lot of people, not just breast cancer patients, but I find a lot of people post-surgery or post-injury, quite often people have had good advice and they've understood it, but they're still not sure exactly how much to push things. They need reassurance on activity levels and how much they should be doing at a certain time, especially if pain's involved. So in terms of treatment with the Primus, I think I'm just missing a slide there, actually, Andy. So I did have a slide that was on, I'll just go back to that. So when our initial treatment with the Primus, we used to give her a heat pack to warm up with while she was waiting for her appointment for 10 minutes. And then we would do some CPM activity on the Primus. So in terms of that, we used to get her doing about 3 minutes of CPM into abduction, into forward flexion, and she did external rotation as well. So I did have a picture of that, but I don't know where the slide's gone because it was there just now. But for those of you that aren't familiar with the Primus or these terms, so that was continuous passive motion. So basically, the machine is taking her through those movements, and we were using that both for a warm-up stretch and also to actually as a stretching treatment. And also later on, she did some PNF type stretching. After Sarah liaised with Jeff for some advice, we added in some use of the cable attachment on the Primus to do some PNF patterns, so kind of using different planes of movement to give that anterior stretch. So not only was she abducting her shoulder, she was also flexing it, extending it in a movement pattern. The other things we did on the Primus was Jeff told us about a breast care battery that had been developed. So this is kind of a battery really of different things that are relevant for these patients. And so there was various isometric strength testing within this. So she, I think I've got an example of this on the next slide. So this slide actually shows some comparative strength testing. So I think this has got something for everyone, like visually, even if you're not technical whatsoever, you can see that the right side's stronger than the left from the graph. So for a patient, it's brilliant. From our point of view, we can see figures, so we can see that it's not very big, but on the left, her average was 38 pounds compared to the right, just under 54. So there was a difference there, and I'll show you the difference when we retested after her program a little further on. So we built in this strength work as well into her programme, because we found that abduction and external rotation in particular were weaker than the other side. And I think it's one thing that we always do. You'll see from the information that I give you later on that this Mrs. A came a number of times, and you can see that we're not seeing her weekly even. And so a lot of our patients we get in weekly for their rehab, but that's not enough to see any change. So we make sure that they have supplementary programs for strength as well to do at home. So she was using TheraBand and doing that every day. And although TheraBand is not objective in that you can't see the results, it doesn't matter because she's carrying on that treatment and then she comes back to have the objective measures on the BTE. So these are some of the attachments that she was using, including the cable attachment 191. I've just put some testimonials in here for the Primus because I love a testimonial, and I just think we need to keep asking our patients for feedback about what's important to them, and our patients are very passionate about the Primus, and I think the third quote down is really one of the ones that people say again and again. They love the visual aspect of it. They love being able to see a graph going up, that they're improving. And what I've found is really that the qualities of the Primus really can improve people's confidence and also their sense of self-efficacy, that they can actually complete a task. So it doesn't show so much in this actual case study, but I've had people where they're not confident to get back to work, for example, and they might have something with a pain component and condition, but when you simulate that activity with them on the machine, they feel like they're doing it. And even if the forces involved are less than the forces they would have to do in their job, just the fact that they're seeing themselves doing it and might see figures going up is enough to make them confident that they can do it. So I love those aspects of the Primus. We also use the LymphaTouch now. The LymphaTouch, we've had it now for quite some time, but when Mrs. A came into our service, we hadn't really used it because we'd only just got it. So we had Dom from PhysiQuip come and agree to actually treat this individual with it. So she had a session with the LymphaTouch with Dom and the therapist that was seeing her. And she actually, by the time she was treated with the LymphaTouch, she was coming more towards the second third of her program, I'd say. So she only had a few sessions with it until she had actually reached her goals. But in terms of the LymphaTouch treatment, she had some initial sort of discomfort and tingling, but every time she came, that improved more. And when I've been using it with people subsequently, I haven't found anyone that's had a problem with it, with what we've done with it. And so that's really promising. In terms of the technical aspects of it, we tend to use it, we don't use it to address lymphedema as such. We use it in a very localized way to try and release soft tissue and scar tissue. So we were using it in and around the mastectomy scar that you saw earlier. Now, if I can just go back to that. Yeah, so a typical mastectomy scar, and this picture I didn't say earlier, but this is a picture well after this Mrs. A had finished her treatment, so it looks like she's got great movement. Sorry, I should have mentioned that because you might be thinking that movement looks great. She agreed to do some educational material for us, so she consented to have photographs taken in a series to help other people with scar management, etc. And that's all in production at the moment. And she obviously consented to me doing this webinar too, which was very good of her. But we used to use the LymphaTouch over and around that scar tissue in a very localized way. So we would start off with, well, I would normally start off about 80 millimeters of mercury pressure, and then gradually build up to 180 plus with people, and it's always been okay. With the breast cancer patients, we wouldn't ever use that or manual massage with anyone that was having radiotherapy because of the skin soreness, etc. And we would just monitor really, really closely people's response to it. We use the different techniques. I know other people have touched on that in other webinars. So we do use different techniques, and we sometimes use it with emollient and without emollient. So what we're trying to do really is release tissue in different ways and at different levels. And we also get people to get in different positions while we're using it, so that we're just trying to mobilize tissues. Yeah, so these are some testimonials, and these are all testimonials just from our breast cancer patients that have used the LymphaTouch, that we've used the LymphaTouch with. So we use it for a total of between about 10 and 20 minutes total. And so I think some of these comments, I think especially the bottom comment, my scar feels softer, more flexible, it feels like you've had a tissue massage for 10 to 20 minutes of treatment. I think that's a really positive comment, because everyone's under pressure with time. So we were very lucky, because our occupational therapy assistant, Amy, who worked with this client group, actually was very used to doing manual massage because she was trained in massage. So that was not a skill that every OT assistant has, but she happened to have it. So she and Sarah used to do a lot of manual massage, and this patient A, Mrs. A, actually had quite a lot of manual massage in addition to the other treatments. She had a home program of stretching, positioning, strengthening, and I wanted to touch on a couple of those things. In terms of stretching, so like I touched on before, if we're doing treatment here, most things we try and replicate with the person at home, so they've got carry on through their treatments, because it's not enough to see people once a week. We get partners involved if both parties are happy for a partner to be involved, and so it's actually quite challenging sometimes to stretch this area just from a comfort point of view. So you have to make sure that you talk through with people where they're going to do it, what position they're going to be in. I often suggest that people lie on their bed and do it. Sometimes if they've got something to kind of hold on to at the back of the bed, it takes the pressure off them kind of needing to feel like they're actually positioning their arm on a bit of a stretch. Going on to positioning, with every patient I have, with every breast care patient, I always ask them what position they sleep in, because I think I've not read this anywhere. I'm sure other people do it as well, but I just think if we go back again to so that you can visualize the scar. So if you think about Mrs. A and where her scar tissue line is, if she was someone that slept on her left, a side sleeper to the left, I'm a side sleeper, and I really kind of hunch up, so everything's really shortened in that area. So if she was sleeping on her left hand side, if she was lucky enough to be able to sleep 8 hours out of 24, for example, that's a long time. And if we think about soft tissue, the nature of soft tissues and scar maturation and just tissue tightness, when we're trying to lengthen tight tissues, etc., I think that's quite a long time to be at a very shortened length for. So I just think it's always worth educating someone as to what position their scar might be more at length in, and then suggesting that they try sleeping like that. So if I had a scar where she's got one there, then I would try sleeping on the right hand side with my arm propped up on a pillow or some towels or something, just to get some length to the tissues. They don't have to be on a stretch. You've got to be comfortable to sleep, but I do that advice with everyone, and I think about 40 to 50% of the people that I ask how they've got on say it's been helpful. So I think it's worth trying. Don't know what other people think of that. All the advice and education that you'd normally give, we give a lot of advice and education. We work really closely with our multidisciplinary colleagues. So here we get referrals from the breast care surgeons, the breast care nurses, a lot of radiographers, our physiotherapy colleagues, and the occupational therapy newer service refer to each other, so inter-referral. We all can signpost as necessary, so to charitable organisations, support groups, you know, things like that. And as occupational therapists, in our normal work in upper limb trauma and burns, we're very used to doing return to work rehab, return to work planning, liaison with employers, and those kind of scenarios. So that comes into the rehab too. So her outcomes, so she had 19 appointments over 8 months. So we haven't had anyone that's had anywhere near that amount of appointments actually, but she, like I say, was one of the first patients. And I would say our average appointment number is about 3 to 4 with this clientele. She, at the end of her discharge, she'd returned to work, normal duties, normal hours. She'd returned to all her hobbies. She had really good outcomes in terms of function, pain, movement. She still retained some element of tightness across her chest, and she still retained some cording, but it wasn't anything that stopped her doing anything, and it wasn't anything that interrupted sleep or anything like that. Sarah and Amy did a fantastic job in a very busy period of actually collecting data and trying to be good at measuring outcomes, which, as everyone will appreciate, is very difficult in a fast-moving environment, but really important. So we collected a variety of outcome measures. These are just some of them. Because treatment is always individualised, we use different outcome measures for different people. But Mrs. A had a DASH score that went from 33 to 14. And in terms of the DASH, if you're not familiar with the DASH, it's a really widely used outcome measure over worldwide in hand therapy, upper limb therapy. And we used that with this lady. And that score, I think with the DASH, a minimal important clinical difference is 10 upward, 10 to 15, I think I've looked in the literature. And so that shows that there was a clinically important difference. We also use the EQ5D score, which, if you're not familiar with it, this is a score of quality of life score, very generic type score that's used. It's got 5 dimensions: pain, self-care, usual activities, mobility and anxiety depression. Now, I've not included mobility and anxiety because those scores didn't change and they were either nothing or very mild. Pain improved somewhat, self-care improved, self-care and usual activity improved, but pain was the biggest improvement. Obviously, she had big improvements in her movement, and she didn't have any flare-ups of her lymphedema throughout the treatment period, so nothing seemed to exacerbate that, which was good. This is a picture of so you've seen the slide on the left already. That was testing external rotation, isometric strength, right compared to left. So just looking at it again, you don't need to really see the figures unless you're the person treating the patient. You can see that over the time, that was over about a 4-month period, right and left have become more similar. So you could deduce from that she's relying less on the right and using her left side more, which is good. I don't actually know what the normal presentation, the difference between left and right strength would be. Maybe Jeff can comment on that later. But to me, that's showing that the treatment she did made a difference. So our service, so it's just over 2 years since we started all this and treated Mrs. A. I can honestly say that I'm not aware of any negative feedback from anyone who's attended the service, which is really good news. We don't have a massive caseload because our core, as I said before, our core workload is hands, burns and plastics. So we have a big clinical caseload doing those things already. So I think in the first year we got about 35 referrals for the breast care patients, and I think now we get about 3 to 4 a month. We've still been getting them all through lockdown, which I'll talk about in a minute. So as I said before, we have different referral sources. When I audited the first year, they were really good outcomes, but very, very small numbers. So, you know, it was just interesting to see what was happening, really. They were small numbers. They were made even smaller because we were using such a variety of outcomes, and we didn't use a battery. We didn't use the same battery of outcomes for every patient because they had different needs. So I think the thing that was most notable really about what's happened with this is that the radiographers are referring more and more because we've facilitated a lot of people to be able to start radiotherapy. So we get referrals saying Mrs. B can't start radiotherapy because she's unable to reach the position required for this. So the position, if you can see me okay, is kind of a bit like this. So quite a lot of shoulder flexion, abduction, and you might have to be in that position for up to 20 minutes or so. So, you know, we've had a lot of people that just can't start their radiotherapy cancer treatment because they can't get in the position. And people have managed to achieve that within 1 to 2 sessions. And on this slide it says some, but actually, having talked to my colleagues, it's quite common that the people that referred can have 1 to 2 sessions and then go on to have their radiotherapy. And with those patients, sometimes we don't see them again because they're okay after that, and we've just done that bit of facilitation. I didn't tell you how long our sessions are, so we usually spend an hour and a half with the patient to begin with, and then treatment sessions after that might be usually an hour. So that's something that when we fed back to the breast care team as to what we're doing, they were interested then in looking at the pathway and introducing occupational therapy into the breast cancer pathway. So we're currently in therapy as a whole, looking at our pathways, and the hospitals are as a whole are looking at all the cancer pathways as a whole as well at the moment. So I think in terms of other developments, just checking I haven't missed anything. Yeah, and just following on, just nearly finished now, but other developments that have happened. We actually sadly lost one of our patients because her cancer returned. And so she started having some treatment with us, but it wasn't progressing as a lot of other people have progressed. So we were obviously really careful. Not only was this not traditionally our clinical area, so we were very cautious and made sure that we were talking through what we were doing with the referring parties, etc. But also with pain, we're very cautious if someone's having pain. So this person, her cancer had returned and she sadly passed away. But she felt, her partner contacted us after her death, and he said that she had wanted to donate some money, and I'm welling up a bit now. I am passionate, Andy, and it's quite an emotive subject, but she made a donation, and her brother made a donation as well. And excuse me, and myself and Sarah, pictured there, have done a bit of fundraising, and we are going to use that money to make one of our treatment rooms here in the hospital. We want to create much more of a spa-like feel and a much less clinical feel. So you can't get away from a clinical feel in a big busy, bustling clinical hospital, but we can create a little haven, and so we're planning to do that. And just to finish off with, like everybody else in the world, the last 6 months or so have just been, everything's been turned upside down, including all the therapy services at UHL. A lot of the rooms have been taken to use for other things. A lot of the staff have gone to work on the, on the wards when they would have been working without patients. And so, but we have carried on with taking our referrals, and we've been doing appointments virtually. So we've used phone and video links, and but people are really desperate to get back in and get some treatment. So we have tried to see the odd person when they're coming to clinics anyway, like in maybe if they're coming for a radiotherapy assessment or something like that. So we're just watching this space really, and hoping to get back treating people soon. And we know our managers are working really hard to enable us to do that. So I think I've covered everything. Thank you.
Thank you, Rosie. That was great. That was really good to hear all the work you've been doing there, and I like the sound of that spa. That does sound sounds like a nice place to be treated. So one question that I've got as well, which I'll actually bring Jeff in. So we're now joined by Jeff Johnson, who is clinical application specialist at BTE as well. And you were talking about the patient A there, Rosie. Jeff, where do you start with someone who comes through who's got so many strength deficiencies? Where do you start with that sort of person?
It's a really good question. I think Rosie did a great job of pointing it out that in that baseline evaluation, the isometric assessment that was performed here looked at a simple function, looking at the shoulder. And you're looking to see what is asymmetry. Is there a significant imbalance? Is there a significant weakness? And once you do that assessment, you can really build your treatment program from there. It doesn't matter how frail or how weak someone is, you can certainly get an objective assessment on basically any type of movement, an isolated movement to a fully functional movement. And then from there, build more exercises, build more isotonic treatment as tolerated. Certainly adding in that CPM that Rosie was doing quite a bit of. That I can't even imagine how beneficial it was early on for a person to feel that. And she showed, 50 and 60 degrees improvement in just a few sessions. So that's significant. And that turns into improved function and quality of life.
Thanks, Jeff. Anything to add on that, Rosie? Did you have a sort of particular thing that you would try and work every patient through, or is it you just do it on a case-by-case basis?
I think quite often with these individuals, it is similar things. So it's often abduction, forward flexion, external rotation. But like I said, we don't tend to, it was really good looking at the battery, but we find the same actually when we're using the Primus with our hand patients. I think in occupational therapy generally we use it very functionally, and we use a lot of work simulation and task simulation. We do try and strengthen specific muscle groups and things like that sometimes, and we test specific planes of movement, in comparison to the unaffected side. But we do very individualized programs. So although the Primus has lots of, it has different, I can't remember what you call them now, Andy, batteries of treatment for, say, someone that had a wrist fracture. So if you work in a department where you're seeing hundreds of people that have had wrist fractures and have similar things that they're working on, it can be very time effective to use templates, but we very rarely use templates. So we do things quite an individualized way. I don't know if that answered the question.
No, that's helpful. That's helpful, and that leads quite nicely into the first question we've got from the audience. So, when assessing strength and range of movement, do you take into account whether the limb is dominant or not, and how do you ask what else they do which might impact on this? I think that was a nice point that you made about getting people back to normality and returning to work or everyday life. So, how do you take that into account?
Yeah, I mean, we normally ask people in our initial interview, we'll ask people about their normal routine, we'll ask people about their employment, and sometimes you can find out things from that. We always find out, which the dominant side is. In terms of, like I touched on before, strength, etc. So I don't know if it's about 10% different. I don't know if it is this case throughout lots of different muscle groups in the body with left and right, if it's up to about 10% difference. But certainly in things like grip strength and stuff like that, I would take that into account if I was testing someone's grip strength. I think so the question was whether we take into account their dominant side in terms of range of motion and strength, wasn't it? So I think we do, but we, we don't get too figure orientated and data orientated. We try and step back and see a bigger picture as well. I don't know if you want to add anything to that, Jeff.
I think you nailed it, Rosie. There's an obvious difference between an involved versus an uninvolved side, but also taking into account the dominant versus non-dominant side, very important. We can objectively see this like you did with this patient. And not only that, you then have the information of what they need to do to return to work. That's a really great point here, is that it's not only just about restoring just basic movements, but getting this person back to some level of normalcy. Most people want to go back to work. Most people want to go back to doing things that they enjoy, their hobbies, golf, tennis. So what you're doing here is wonderful, in that you're individualizing each patient and what it is that they need, and you're able to put a program together for them for those goals.
Great, thank you. Next question. So you mentioned the multidisciplinary team, Rosie. How has that worked? Has that been an easy transition? Like, I think sometimes like the surgeon therapist dynamic, how has that worked?
Well, it was quite interesting actually. I was due to I was actually due to go off on leave to start a family when I contacted. It was only about 2 weeks before I was due to go on leave, and I just contacted the breast care team, thinking that I would take this project up when I got back a year later. And the lead breast consultant said, "Oh, can you come and see me tomorrow or on Friday or something?" And so I went to see him and just talked to him about it. And he was keen then for me to talk to the whole team of doctors, nurses, radiographers. And so I went to do a presentation to them about what we might be able to offer with our service. And again, thinking, okay, I'm finishing now, the team's going to be very busy because they're a member of staff down. I didn't expect anyone to be able to actually put anything into action until I'd come back a year later, but Sarah and Amy did, and the whole multidisciplinary team came on board. And I think sometimes you just have to try things, and we tried it, and you know, there are benefits that have come out of it, and I'm not sure where. It's like I said, we're reviewing all the pathways and things at the minute anyway, but everyone's been really, really positive. And since then, we were always involved with breast care patients before with our plastic surgery breast reconstruction patients. So we did a lot of scar management with those patients. So we work very closely with our plastic surgery nursing team and our plastic surgeons who do breast surgery. But yeah, the whole new group of people who OT were new to were very positive, and so very positive experience, really.
Great, thank you. So back to the questions. Did this Mrs. A, did she have lymphedema as well? And if so, was she taught self-lymphatic drainage as part of lymphedema management?
Yeah, she was. She was under a specialist lymphedema clinic that runs here in Leicester. So she had I would say mild lymphedema when she started in our service, and she had a garment and she was taught to do self-treatments. And she used to come to us, and actually she used to take her garment off to do the therapy. That was her choice. And we were monitoring that carefully, but she didn't have any apparent exacerbation of any of that. So, but it's a specialist. We have a specialist lymphedema service here in Leicester, and so we talk to each other, but we don't ever treat anyone there, and they don't come here, but we are in close contact.
Okay, and are there any specific forms of exercise that you would recommend as part of rehabilitation for this type of patient?
I would say, well, general kind of exercise. I think people have their own specific interests. So I've just discharged someone actually that was a keen tennis player after a mastectomy, and so she was keen to get back to that. But I think to start off with, things like swimming and you know, walking and just general forms of exercise that aren't going to be necessarily too, I think something like tennis, for example. I advised this person to, I mean, she was fit anyway, so she was fit to start with. So she was just regaining her fitness. So with her, it was a question of just gradually building up activity and then monitoring very carefully. So like breaking up that activity. Because she was right-handed, it wasn't the racket side. She had a left mastectomy, and it was actually throwing the ball up. She was a bit worried about doing that, but it was just a case of saying, well, gradually work up to it. So do, you know, a graded return to it. But I think it's widely known that exercise is good for loads of different illnesses and sorry, I've forgotten my words, sort of loads of different conditions and things. So just whatever form of exercise is good, but the more gentle ones, perhaps that are less impacting around that area to start off with.
Okay, thank you. And how have you justified the investment in these two technologies?
Oh, I meant to say actually, our LymphaTouch, for example, I meant to put it on the slide actually. We got our LymphaTouch from a UK-based charity called Dan's Fund for Burns, and we use it with our burns patients. So they actually paid for the initial outlay, and then we had to justify to our hospital, we had to just tell them what it would be used for, and to justify the ongoing costs associated with that, like new cups, new filters, etc., etc. So thank you to Dan's Fund for Burns. When we're not treating it with burns patients, we use it for other people, because I think it's really important to maximise the use of particularly pieces of equipment that are more sophisticated and perhaps cost more. The Primus, well, the Primus we've had our current Primus for over 10 years, and it's served us well. And but I think over those 10 years, the situation in healthcare's changed a little bit, in that money's even tighter than ever. So I think it's my my life's work at the minute to try and get another Primus. And I've been working on that with Andy for, I think, the last 3 years. We originally got our Primus out of hospital capital funds, but it's a lot more difficult to do that in this climate. So we're just working on bids at the moment. And I think what I would say with that is, be persistent and keep gathering the evidence, and all different forms of evidence. So you need outcomes, you need the patient's perspective, and you need basically, you need to justify how it's going to help all the different stakeholders in the process. So the people that are funding it, the people that are using it, and the community as a whole, really.
Yeah, definitely agree with that. We'll get there with that one. So we're here to help on any of those questions as well.
If anyone in the audience has got a bit of spare cash.
Yeah, exactly. Okay, so how did you manage your scars before LymphaTouch?
We use manual sort of massage and manipulation techniques. So we would try and, I found it very difficult with very dense, thick burn scar tissue to do this. But with techniques like lifting, trying to lift the superficial skin layers up, kind of creating your own vacuum, try and do that manually. We've tried different things like actual manual suction things. I tried to liaise with I know in some places people use suction. I know in another local hospital, people have used suction from the normal suction machines you might get on ITU or whatever, and I've tried arranging that before, but I found some things were so logistically a challenge that it didn't work. But basically, cream massage, manipulation, stretching, positioning, activity, exercise, I think that's about it. Making sure it's nice, all the area is nice and warmed up before you're doing that. And we also, for our burns patients, we use pressure garments. So we get custom-made pressure garments made. We have a mini massager, so sometimes we'll use that. We've got a Niagara massager, we use that. There's 3 hospital sites in Leicester, so we haven't got the same equipment at each site. We're very lucky at the Royal because we've got the LymphaTouch and we've got the Primus. The other sites have to use what they've got on those sites, but we do most of the scar management and burns treatment, which is why we've got the bulk of the the equipment like that.
Perfect. Thank you very much. No, well, I really appreciate that, Rosie.
We
That
use
was
silicone gels as well. We use silicone products as well.
silicone gels, great. Okay, thank you. So we're going to finish that there. So big thank you to Rosie and for Jeff for joining as well. Rosie, could you just skip on 2 slides, please?
Pardon?
You just skip on and then the next one as well, please. Just one more slide. There we go, great. So I just want to bring your attention to a session that we're running next week on the implementation of a lymphedema prevention pathway. So tying into what we talked about today, lymphedema can also result following breast cancer surgery, and it really can cause a huge detrimental impact on the patient's life. So this particular pathway that will be discussed next week has already been used and proven by governing bodies in the States and in Australia, as well as other countries. So we've got a key opinion leader from both a clinical and research perspective in Australia who will be talking about how they've researched and proven it works, as well as implemented it. And we've also got a UK clinician who's been using this early detection pathway for the last 4 or 5 years. So if you have got any interest in that, please join next week. It's an earlier start, but hopefully you can make that one, even if you can't register, and we'll send you the link afterwards, because that's going to be a really, really interesting thing, because this is going to become a big thing over the next coming years. So other than that, if you do have any questions, whether it's for Rosie, Jeff, or for us, then we're more than happy to help. So send them through. We're going to be running many more of these sessions, so please get in touch with us. We'll be sending a feedback questionnaire, so fill this in, helps us to improve things. And other than that, have a great Friday afternoon. Thank you, Rosie. Thank you, Jeff. And yeah, we'll see you soon.
Bye.